work that we've been doing over the last year that has been the grateful opportunity through Department of Environment and local government to be able to conduct additional work on heat. Just want to acknowledge the research team. So one of our research team members is here, Farnaz Grobani, and Farnaz was responsible for the technical work that was done in the lab. The rest of our team really helped to inform our work in the lab. Julie, of course, from Department of Environment and Local Government, and Calvin and Shane, both epidemiologic public health researchers with specific expertise in heat and environmental epidemiology. And of course, I see some folks on the call, Melissa specifically. Special thanks to you for providing us with the daily weather data that we were able to use for the project. So as with all NB-IRDT projects, it's really important for us to make acknowledgements, but also to identify the project data that we were using. So just to acknowledge that this work was supported through funding by the Province of New Brunswick Climate Change Fund and the Maritime Spore Support Unit. And no endorsement by MSSU, the Climate Change Fund, GNB, Environment and Climate Change Canada should be intended or inferred. We access platform data, so this is secure personal level health data within the secure facility. We access them at NB-IRDT, UNB Fredericton, and these were data provided by the RHAs, GNB, Department of Health, as well as open source weather data that we obtained directly from Environment and Climate Change Canada. I was going to say the acronym, but I was getting a little bit tripped up. And then green and blue space data that we obtained from the Canadian Urban Environmental Health Research Consortium, or CANU for short, and just detailing some of those data sets as required as the part of their acknowledgement requirements. All right, so now getting into the project itself. So Healthy Environments Branch are reviewing the provincial HARS program. And so they reached out to us a couple years ago now to develop a research project that could help inform some of the pieces and things that they were thinking about. So they partnered with us to develop this research study to help inform their decision making. So the work that we're presenting here is directly related to those discussions. The Healthy Environments Branch are the ones that secured the funding for both phases of this work. The first phase of this work was presented last year around this time, and the focus was on heat exposure in vulnerable populations, and that work was specifically funded through the Environmental Trust Fund, GNB Environmental Trust Fund. And so this slide deck that I'm showing you today is primarily focused on phase 2 of the results. So just a bit of a background. So projections suggest that annual occurrence of extremely hot days in Canada, including New Brunswick, could more than double in the next 30 years. So this is particularly important because populations in the northern countries, like New Brunswick, are expected to be impacted to a greater extent, as we're not really acclimatized to these high temperatures or extended durations of these high temperatures, because prolonged heat waves or heat events contribute to adverse health outcomes with longer and more intense heat events posing higher risks. And what we find from the literature is that vulnerable individuals might be affected earlier in the heat event, leading to a spike in the immediate risk, and a subsequent decline, which is referred to in literature as a harvesting effect. And I'll get into that in many slides. Urban areas are found to face compounding risks due to increasing number of hot days, but also because of urban heat island effects and limited vegetation. Vegetation is one part that we looked at in this study as well, so we'll get into that. So phase 2 had 3 parts. So the first part was really to examine the relationship between temperature, humidity, really the dynamic relationship, and their effects on health outcomes. We examined how prolonged and intense heat events affect health outcomes. So these first 2 parts also help to characterize the burden on the health system following extreme heat events. And this was part of the modeling strategy that we selected that is a best practice for this type of work. And so as a part of the output of that model, it provides us with this information. So we'll show you some of those findings as well. We were really interested in understanding some mitigating effects. So as a first step, we're looking at here green and blue spaces. So green being vegetation, so grass, trees, etc., and blue spaces being strictly water spaces, so rivers, oceans, lakes. And in research has been suggested to have some mitigating effects, and so we wanted to explore these here in New Brunswick. Many of you likely know what NB-IRDT is, but just to give everyone a common understanding, NB-IRDT is a research data center. So we are defined in legislation as a research data center, and which allows us the legal authority to receive, hold, and grant access to personal level linkable data on New Brunswick residents. So this is restricted to the provincial borders, but we have a range of data across different government sectors and other sectors across the province. And really the purpose of NB-IRDT is to help governments like yourselves and communities and other partners make trusted, informed decisions for the benefit of all. So what we do is we have the expertise in this population health data, in research methods, analytical approaches, and data governance and data privacies, and putting these pieces all together, which is demonstrated in this image, really allows us to help support and engage in this purpose and really help to further the use of data in New Brunswick to help inform on some of these key problems at the population level mainly. So now getting back into this specific project, this is just identifying the data sources and the data sets that we use for the different components. So cohort development, so identifying who we should track heat and outcomes on, we were strictly using the Department of Health citizen data. So this is the Medicare registry that anybody in New Brunswick with a healthcare card is included, and it includes information about residential, so we can identify when people move. It also includes information about death, so when they die, they're no longer in the cohort, for example. It also includes information about people leaving the province, so which was important for us to be able to identify who was here throughout the summers. Weather and environmental indice data were used from Environment and Climate Change Canada, as I acknowledged in one of the first slides that Melissa provided us, but as well as the canoe data. And so the green and blue snakes was the data that came directly from canoe. The health outcomes were focused on data that we had from Department of Health. Department of Health data was used to characterize hospitalizations, but also death using the citizen database. The vital statistics database is the better data set to use for death, but because it contains causes of death, but these data are often lagged. So we decided not to use them for the purposes of this project because it didn't cover our whole study period when we were planning to do the study. And so we use citizen database because when someone dies in the province, their Medicare card is automatically terminated. And so this identifies individuals who have died, but we don't know why they died. So that's a limitation. Discharge aspect database was identifying hospitalizations, and we were really strictly focusing on unplanned acute hospitalizations, so limiting things like elective surgeries or direct entries into hospital that weren't planned. Sorry. And a Vitality and Horizon emergency room data were used to capture outcomes of emergency department visits. Vulnerable populations were generated using Department of Health data, mainly the citizen data, as well as the Canadian Chronic Disease Surveillance System data. This is a PHAC algorithm type of data set that allows us to identify people with specific chronic conditions, as well as the Statistics Canada Canadian Index for Multiple Deprivation. And this is an index of using census data that captures different socioeconomic conditions at the neighborhood level. So vulnerable populations was a big focus of phase 1, as I mentioned. In phase 2, we sort of just use the learnings from phase 1 to identify who we should group as this vulnerable, we should categorize as this vulnerable population. And in this work, we've just grouped everyone together. So it's limiting, but it's a first look at this. So just giving you a bit of a sense of the study population, as I mentioned, we use the citizen database, which is the Medicare eligibility, to identify individuals living in New Brunswick during summer months. And we define summer based on months of May to September. But through our data analysis, we do recognize that there are limited numbers of hot days on months of May and September, and primarily focusing on those summer months, as you would expect based on your experience. And we did this for each year from 2007 to 2021. So we considered each year as sort of an independent sample of the population or a cohort. So we use Statistics Canada Postal Code Conversion Plus, or what we say PCCF Plus, to geocode individuals' six-digit postal code. So six-digit postal code is the most specific address information we have at NB-IRDT right now, at least, to geocode individuals. Farnaz and I, because of privacy concerns, don't access the six-digit postal code. So this geocoding was done by the individual that is part of our organization that does have access to those data, and that's our database administrator. So he is the only one who has access to those more detailed informations. And so DAs are small areas of relatively stable populations ranging from 400 to 700 people living in each DA. And in New Brunswick, we have just under 1,500 DAs. So each person was co-located to a DA depending on where their postal code was. And then we used, or Sequan, our database administrator, used ArcGIS to calculate the distance between each person's DA and the 13 weather stations that we included in this analysis. And I'll show you those in a next slide. We identified stations that were co-located with hospitals, primarily just to control for some of the key behaviors around that. Stations that are further from hospitals, for example, those individuals may have different behaviors than those who are closer to hospitals. So we just wanted to sort of keep that more consistent. And so our study cohort includes all New Brunswick residents that lived here for the entire summer. And remember, we considered each summer independently, with each person assigned to the closest weather station each summer. So if you moved, your weather station would change depending on whether there was another weather station that was closer. And we did that annually. And we needed people to be here for the whole summer. So they had to be in New Brunswick from May to September. If they came like from another province to New Brunswick in the middle of the summer, they weren't considered for that summer. They would likely be considered in the next summer if they remained in the province that summer for the whole summer. And it was based on residential. So we don't know if people went on vacation, for example. It's just about their residence, because that's the data that we have. So this was really important for us to be able to define a defined population or cohort so that individuals could serve as their own controls. So we're comparing each person's outcome on a day that, say, is not hot versus a day that's hot. So this was part of ensuring the robustness of the design. So I mentioned that we had 13 weather, but these were the 13 that we identified that were co-located with hospitals. So the green diamonds give you a sense of where those stations are. And so the stations are relatively distributed across the province, although we have smaller areas that aren't covered. So this is where there's potential limitations in the approach that we identify people closest stations. So there might be more distance for people to travel depending on where they are. But this was a first look at this data. We did look at an approach that we used in phase 1, which restricted individuals living within 40 kilometers of a weather station, and the results were quite consistent with what we found. So we considered 3 health outcomes in this work. We also considered 3 health outcomes in phase 1. So this is the same outcomes that we had informed on previously. Emergency department admission data from Vitality and Horizon only started being collected in 2017. So it's only available for the most recent summers and only 5 summers. So the power was more limited in those analysis, but because there's more emergency room visits each day, there was sort of a bit of a trade-off. So the results do seem to have sufficient power based on what we found, but we acknowledge that with more time, we'll have more reliable estimates. So what we did for each weather station, we identified the individuals and did they have on each day, did they have one of these 3 outcomes? And if they did, we summed those outcomes at the station level. So Fredericton Station, we defined how many people were in the region of the Fredericton Station, and then how many deaths did they have, how many unplanned hospitalizations, how many emergency department visits, and that was our unit of analysis, the day, not the person. So what we did was we compared the average number of health outcomes on a heat event day to the average on a typical summer day. So just since there's three parts, we broke it up so that we talk about part one, methods and results, part two, methods and results, part three, methods and the results, so that we're not making you remember everything that you had uh, needed to previously. So as I mentioned, the first objective was to examine that dynamic relationship between temperature, humidex, and health outcomes in New Brunswick. So daily maximum temperature and daily maximum humidex were used to define heat exposure, and we modeled them as continuous variables. In our previous work in phase one that we presented last year, we categorized days, whether they met the heat alert criteria or not. In this case, we've used the continuous values, and this improves sort of the understanding of what's happening because we acknowledge that in our first phase that we had some ambiguity around the relationships around those temperature values where we had that cutoff, had to create that cutoff, which is 30 in terms of a temperature as an example. So health outcomes on hot days, and hot days we defined, which is commonly used in the literature as the 95th percentile of the weather metric. And I must say also that maximum temperature, maximum humidity is also very commonly used in the literature. And so that's why we chose those as our primary metrics. But as you'll see, we do explore different metrics just to see what happens. And what we did was compare them to the median value. So that's kind of a typical summer day over those 4 summer months, or 5 summer months, sorry. And we quantified the relative percent increase in ED visits, unplanned acute hospitalizations, and mortality. So what is the relative percent increase in number of outcomes when we compare, in our case, we're going to share results about 30 and 36, 30 degrees Celsius and 36 humidex, and relative to that typical median value. So heat vulnerable populations were defined as we did in phase one, except we restricted some of the populations based on what we learned. So we looked at demographic, socioeconomic, and health-related characteristics. So just to point out a few differences for those who were here last year, the demographic piece in the phase one, we looked at children aged 0 to 18, whereas in this project, we restricted to younger aged children because we identify from the literature that this is more of a vulnerable population. Also from the phase one, we had defined socioeconomic vulnerability as individuals who were living in areas in the top 2 quintiles, so the top 40% of the population, the worst 40% of the population, and so that we identified that perhaps, and because we found some really interesting findings, we thought that perhaps for this more conglomerated group of vulnerable populations that we would restrict to that highest 20%. So these people in this study are those most vulnerable from a socioeconomic perspective with respect to the data that we used, of course. And then health-related characteristics. Previously, we looked at diseases and conditions individually in phase one, whereas here we've just grouped everyone together. So previously we looked at comorbidity, for example, whereas here we've just looked at single diseases. So it's potentially more limiting as well. But just grouping them all together is a little bit limiting, as you'll see with the results. So we used a really complicated modeling strategy. You may be familiar with it. It is the recommended or suggested or developed approach for the problems that we have with looking at, weather, temperature on a daily basis, because when we're looking at the relationship between temperature, continuous metric, and health outcomes, we don't necessarily expect that effect to be completely linear. So the distributed lag nonlinear model, or DLNM, allows for estimation of nonlinear effects, and you'll see what that looks like when I show you the graphs, but also really importantly, lagged effects, because of course, if today is hot, it's not, but if it was, it would be not only the effect on today's outcomes, but if it's hot today, it might affect outcomes tomorrow or the subsequent day. And so this model allows us to explore that, to estimate those effects on days subsequent, to identify what is the best lag structure. So different studies use different lag structures. A very common lag structure is a 7-day period. So today is hot. Let's follow you from today for 7 days. And so that is very common, but there are some studies that look at 21-day lags. It seems to be more common in cold research on the other end of the extreme temperature range, but it's certainly interesting to understand what are those longer term effects of a single hot day, for example. We also stratified our analysis to examine how risks associated with heat differed among the vulnerable populations that I defined in the previous slide, but also restricting to folks who are living in the 3 major cities. So St. John, Fredericton, and Moncton. And so these weren't defined as closest station. So it's not people living closest to St. John, but people living within a 40-kilometer radius of the centroid of each of these cities. So it was really restricted to that population. In addition to this more wider range of urban area, we looked at a variable that defines the core population. So these are the people who live like right in the city themselves. And so that's defined using some Statistics Canada geographies, which St. John, Fredericton, and Moncton are able to be derived from. If someone's interested, it's a census metropolitan area, which is both St. John and Moncton, and a census I forget. Anyway, a census, not the different term, but means very similar. And it's just different because StatsCan, the CMAs, which is more familiar to me in using the acronyms, are just larger cities. So Fredericton just doesn't make that cutoff. So they're a CA versus a CMA. All right, so this is the most complicated slide I think I have. I just wanted to show it so that you guys see what this modeling framework looks like to understand what are the things that we considered. But I'm not expecting you to understand it in any way. It's quite complex. So we used a Poisson regression model that allowed us, and I'm just going to use my cursor here to point out specific things, that allowed us to really explore the relationship between hot or humidex in this case on a specific day and its relationship on that day as well as over time. This will be really important because we want to understand not the single day of effects, but also subsequent effects that might relate to that specific day. It's really important to control for time trends because of course we have many years of data, 15 years of data, but we also have some differences across the summer months that we considered. So we included terms that are complicated, and so there's sort of matrices that allowed us to control for this. And the points that we chose in terms of parameters were based on previous literature, but also based on the model fit and discussions with our research team. Also commonly adjusted for in other studies, so we used frameworks and established approaches were day of the week, because of course, Saturday and Sunday effects may be different than weekday effects, or Monday may be different than Friday, for example. Similarly with public holidays, and we included station as a control variable to be able to control for some area level regional variability. All right, so getting into the results of part 1. Oh. Yeah, all right, so just first describing temperature and humidex. So the average and median daily temperatures were very similar. So 21 degrees Celsius and 22 degrees Celsius. And so these were what we used as our reference points. So 22 degrees Celsius is the reference point that we're comparing. Oh, sorry, this didn't turn out so well on the screen. But the temperature ranged from 1 degree Celsius to 37 degrees Celsius. So obviously September and May be more likely to have the lower temperature days, whereas August and July are much more likely to have these higher temperature days. Average and median humidex were also similar. Sorry, I should have put maximum humidex. And so they were 23 and 24. Humidex ranged from -1 to 46, and the 95th percentile, as I mentioned, was used because it's commonly used in previous studies. And for our data, that was 30 degrees Celsius for maximum temperature and 36 for maximum humidex. So now the outcomes over the 15 years of the study, we had just shy of 40,000 deaths, just over 300,000 hospitalizations, and nearly a million, I guess, emergency department visits at the provincial level. Half of these occurred in one of the three main urban areas. The populations of those cities are larger, of course, so it was certainly what we expected. Provincially, there were an average of 1 death per day, 11 hospitalizations, 96 emergency department visits. And in the three main areas, this was obviously higher. We experienced 3 deaths on average in each city, so that's like 9 deaths combined, 24 hospitalizations, and 194 emergency department visits. Just be mindful of the effects because death isn't so common on a daily basis, is kind of what I wanted to point out here. So I mentioned considering this lagged approach. So when we talk about, the effect of today's temperature on tomorrow, subsequent days, we looked up to 7 days. So when you combine all those effects, it's called a cumulative effect. So that's what we're showing here. So it provides the overall effect of that specific day and its impact on the subsequent period. So what we found, and I just also wanted to point out, just oriented to this graph because you'll see a few of these in the upcoming slides. So relative risk is what we estimated from our models. So that's the relative increase in the number of deaths in this slide. I mentioned this modeling approach allows us to be more flexible in terms of linearity. So we were able to use a nonlinear relationship between in this case, maximum humidex and the specific outcome here being death. So a linear model, you would see a straight line through all this data, which is not necessarily the best approach given the shape that we're seeing on this slide, and you'll see some other strange shapes that may be less indicative of linearity. And so just orienting you, this relative risk, the range on each of the slides differs. So we didn't keep it consistent because it depends on the outcome and what that range would be. And if we did keep it consistent, some of the graphs would look strange. So I just want you to be mindful of that. The results are all presented on this side, so you'll see what those show. But just if you're looking at the graphs and see, striking differences, it might just be because the relative risks are, not scaled to that same way. This represents the maximum humidex, and there's also slides that show the maximum temperature, for example. So the daily maximum temperature of 0 degrees versus a daily, here's humidex of 40. You can see as we get to the higher values, we have less data. We don't have many of these days in this extreme period. We do have some, and that's why the data are plotted to that point. But based on what we see, we're seeing that at those extreme temperatures that risk is seeming to be elevated. But because we don't have a lot, we have quite a wide confidence interval. And so for us, this was important to consider for future research. So what do the results show? So the cumulative effects of death in New Brunswick over this period for a maximum temperature, for a maximum humidex of 36 was associated with a 5% cumulative increase in death over a 7-day period. Similarly, a maximum temperature of 30 was associated with a 4% cumulative increase. So quite similar, either metric. For hospitalization, this was also the same findings. What we found was the maximum humidex was associated with a 2% cumulative increase in hospitalization, and the same pattern was observed for temperature 30 degrees Celsius, which was also a 2% increase. But you can see here that the relationship is also interesting and different, and interesting to consider what is happening in some of these points. A maximum I just wanted to kind of point out the reduced risk here in hospitalization has been, or apparent reduced risk here at extreme ends that differs from, say, the death, which is kind of pretty spiking, has been suggested that perhaps on very, very hot days that people tend to die more and so don't actually make it into hospital. And so this may explain some of the other findings that you'll see in a few slides. All right, so for emergency department visits, we found that a humidex of 36 was associated with a 2% increase, and a similar pattern and risk was observed for the maximum temperature. So the confidence intervals here are quite overlapped. And I must acknowledge here as well, I mentioned previously that there was only 5 years of data, but because we have a lot more events, the power is sort of offset by that. All right, so then the same analysis that we did in the whole population of New Brunswick for people who lived close to their closest station, we restricted to those folks who were living in one or within 40 kilometers of one of the three main cities. And so what did we find? Well, we found that risk, so you'll see here that the relative risk range is higher now. And so the risk in the urban areas was 11% compared to 5% in the whole population of New Brunswick, which was even higher when we considered only those folks within the CMA or the CA. So that's the core city of Moncton, Fredericton, and St. John. The maximum Humidex, we found a 9% cumulative increase in the three urban areas, but this was similar for both the larger urban area, so that 40-kilometer radius, or their city cores. So the relative risk was the same. So we found a little bit of a difference with respect to the temperature, but not necessarily with the Humidex. For hospitalizations and emergency department, cumulative risks were similar to provincial estimates as well, which is interesting. So also maybe worth discussing. All right, so as I mentioned in our modeling approach, not only were we able to define how weather metric temperature humidex relates to risk of the specific outcome, but we were able to also describe the lag structure in the data. So just to orient you here, again, this is the relative risk, but now it's lower values because this is the relative risk for each day in that 7-day period. So this is the relative risk for the day of the hot day, or this graph is for a temperature of 36, temperature of 30. As you can see, and then this gray area is a confidence interval for that estimate. So increased risk on day one, whereas if we move over, we see on day 0, which is the day of the day after, so lag day 1, the risk decreases. And we see at day 2 similar effects, whereas day 3, the effect now starts to get higher. Similarly for day 4 and day 5, day 6, back to sort of the null line, and then some subsequent decrease here that we didn't explore further, but we certainly could. So what is this saying? We're seeing that there's most drastic effects appear to be immediately, but that this then results in what we found in the literature is referred to as a harvesting effect. So most people who would have, or this is what they say at least, people who would have died on subsequent days where we see a reduction in risk died day earlier because of that heat exposure. So this is what we're seeing, or suggested that we're seeing here, and very common to other studies, none in Canada actually, that report delayed effects. Not that they don't report them, they just haven't described them in the literature. And so we see that there's sort of a emergence of risk in the later days, implying that heat related effects don't immediately cease after that immediate peak. So this is representing a single hot day, not heat waves, which we'll explore in the next section. Hospitalization. So we only found immediate effects for hospitalizations, which much less prominent effects for harvesting or for these delayed effects. Similarly, for ED visits, we found a high immediate effect, some evidence of harvesting that was reducing the risk in subsequent days, and then an apparent increase in up to 7 days following. So the the delayed effects here and the harvesting effects were more minimal than, I'm just going to go back to the death one, than we observed for death, which I think is what is also more reported in the literature. The hospitalization and ED visits have other pieces to the pie that may limit access to services or the different infrastructures, for example. So I mentioned we just combined a heat vulnerable population to look at how the relationships that we've just been showing relate in those people. And what we found was that the results were actually identical or nearly identical. They weren't very informative when we did this. And what we found was it was because 97% of the deaths, 85% of hospitalizations, and 91% of the visits to emergency department occurred among those who we classified as heat vulnerable. We do acknowledge that it's a bit of a catch-all of people, and so we do recognize that, you know, for further work, we probably need to even do further restricting. As I mentioned, we did some restricting from what we learned in the first phase. So we reduced the number of children, for example. We reduced those who are socioeconomically vulnerable, but still, these were most highly represented. So further work, I think, could be done here to understand individual diseases, which is done in other studies, not in New Brunswick yet. So we didn't really find, so cumulative effects were found to be similar, as I mentioned, to the entire population. We chose maximum temperature and humidex as our primary weather metrics. This was based on our reviews of the literature, and so these were our primary metrics. But we were curious as to, you know, what was the impact of using different metrics to define exposure. So we looked at maximum, average, and well as minimum. And minimum daily temperature typically represents the nighttime temperature. And so we looked at average daily temperature because we thought that it might be more accurate to measure someone's true exposure. Maximum, like for example, could just represent like one of the hours in the whole day. So sort of like a peak, whereas the average may be more likely to capture sort of the sustained heat that an individual may experience. So we explored that as well. We wanted to understand what that relationship with nighttime temperature was. And what we found was that the maximum values appear to be reliable. We didn't really find a difference in the overall graphs that we observed when we considered these different temperature metrics. So we were confident that using maximum temperature and humidity was appropriate in this case. All right, so just to give a summary, because that's a lot of information. So what are the takeaways for part one? So exposure to extreme heat is associated with increases in deaths, hospitalizations, and emergency department visits to different extents, of course, with the highest effects observed for mortality, for extreme levels of temperature and humidex, so on those far side of the graph, as well as for the three main urban areas, you know, also perhaps more predominantly within the core of those urban areas. We found immediate effects most pronounced with harvesting effects in subsequent days, but the reemergence of risk in the later days, implying that heat effect do not immediately cease after heat subsides. So we also control for temperatures on subsequent lags as part of that structure. So that helps to control out those effects. But what we found was this relationship was most evident for death, and which is what we also found in the literature. All right, so moving
Sandra?
on to, oh yeah, go ahead.
Sorry, I just thought we'd take a quick pause and just see if anybody has any questions up until now.
Yeah, good idea. Thank
I
you.
haven't seen any hands being raised, but I thought I'd just give an opportunity. Going once.
Nobody's ready yet.
Twice. Okay.
Right. Got a thumbs up. All right. So part two, we sort of extended looking at a single hot day, which is what part one was all about. Now we're looking at extended or prolonged or intense heat events. So looking at heat waves really is the focus of part two. So any day that was a heat wave, and a heat wave is the second day of that hot period. So we didn't define the first day as a heat wave day because that day is similar to other hot days, right? So heat waves are only defined once you have more than one hot day. So any heat wave day was assigned a value of 1 and 0 otherwise. This is the approach that we found suggested in the literature, but we aren't really like that happy with this approach, and so we really want to be able to explore different approaches, but we haven't identified what those are, and maybe they don't exist yet. I did present recently at a presentation talking about the limitations of some of this methodology and posed to the group that perhaps they might want to explore development of some of these approaches because they are experts in theoretical approaches to statistics, for example. So heat waves, we use 7-day lags in the part 1. Heat waves in the literature we found typically use shorter lag days. We did explore longer lag days, but there wasn't really that much interesting effects happening. And so 3 lag days is what we considered in this analysis and is in line with other studies. So day 2 of a heat wave may not be the same as day 7 of a heat wave. And in phase 1, I didn't show that here, I should have. But in phase 1, we characterized the duration of hot periods, and we did find that there wasn't many, but there were some in New Brunswick history that lasted 7 days, and 7 days defined as a heat alert period for the first HARS level. And so this was how we looked at different heat wave definitions. HARS alert was sort of our base, alert 1 was our base, but we looked at 6 others. So Heat Alert 1 in the HARS program includes 2 consecutive days that are above 30 degrees Celsius, and the nighttime doesn't go below 18 degrees Celsius, or 2 days in a row that are 36 humidex. So that's what triggers a heat alert 1. So we looked at that, but we also looked at how does removing the nighttime criteria affect the relationship. We also were interested in if it was both hot and humid, because the heat alert period considers temperature and humidex separately. But what if we consider days that were both hot and humid? And then we also went further extreme and tried to choose categories that were defining very hot and very humid days. So 36 degrees Celsius is what we called very hot, and very humid was above or 40 and above humidex. Then these 4 were for 2-day duration heat waves, 2 or longer, of course. And then we were wanting to understand what does that look like if there are longer duration heat waves, so extending beyond that second day. So looking at heat waves that last 3 or more days. And so we use very similar criteria. Based on the results that we got for very, very hot and humid, the number of days was quite limited when we considered 2-day heat waves, so we didn't look at it for 3-day heat waves. And you'll see the problems with that definition when I show you the results. I also just wanted to acknowledge, I don't think I mentioned above, that the problem with assigning each heat wave day as a 1, it doesn't sort of distinguish between the impact on day 1 and day 7, for example, and it's sort of that averaged effect across all those days. So we really would like to identify a better approach that allows us to look at this in greater depth, but right now this is what we have. All right, so getting into the results. So the graphs align with the different definitions that I showed you, but I put them here just to, I didn't expect you to memorize them. So as I mentioned, heat alert 1 was our first definition, and we found it increased risk of death by 14%. When we removed the nighttime criteria for heat alert 1, the value was decreased to 10%, but the confidence intervals were quite similar as well. But when we considered days that were both hot and humid, so sort of redefining the heat alert definition in a different way, instead of or, using an and here we found a 4% increase in risk of death. When we defined those that were above 36 or 36 and above 40, we found that there was a 36% increase. So this was by far our largest increase, but you can see that the confidence intervals are very, very wide. It's because we don't have many days at all. I forget the number exactly. I should have looked it up to have it in my mind, but I forgot to do that. But the numbers were quite limited, and so that's why we have this wide confidence. But so it'll be interesting to be able to add more years as time goes on, but also increase sample size potentially in other ways to help inform on what is happening when we have this very hot and very humid experience. Because of course, we don't have experience with this type of heat wave, but with the projections, the expectation is that we will have more of these very hot and very humid heat waves and for longer periods of time. So it'll be important to understand what are those impacts so we can respond appropriately and act appropriately when those conditions are met. So this is the 3-day heat waves on death. So HARS Alert 1, so now not defining it using 2 days, but 3 days, we found a 20% increase. So each of these is higher than we found for the 2-day heat wave. Without the nighttime temperature, just as we found for the 2-day, we saw a reduction in the risk. So 14% versus 20%. The third definition for 3 days, we considered the hot and humid, which was quite similar. The previous slide, we found 24%, whereas here, yeah, I was just, my mind slipped. And here we found 26%. For hospitalizations, we saw less of an increase depending on the heat wave definition, but we did find the greatest impact on hot and humid heat waves that last for longer than 3 days. But overall, the confidence intervals were quite overlapping. And one of the suggestions in the literature that may relate to this is that during heat waves, so long extended periods, that people may not make it to the hospital and in fact die before they do make it to the hospital. So this may be one reason why we're seeing what we're seeing, but it's certainly will be interesting for us to further explore what's happening here. And the hot and humid days were associated with a 4% increase in risk of hospitalizations, which is compared to I think it was a 2% increase on the provincial level for a single hot day. So for the cumulative effects on emergency department visits, the strongest effects were observed for hot and humid days that lasted 2 days or 3 days. So we saw a 6% and a 7% increase in risk of death, depending on what the definition we use. But both of the definitions were defined using this combination approach rather than an or. But I guess I should just also point out while they're higher, they're quite similar to the heat alert current definition. But when those things happen together, maybe there's a need to act differently, potentially. All right, so just to summarize again, lots of information, and I just wanted to kind of bring it all together and sort of give you the takeaways. So intense and prolonged extreme heat exposure is associated with greatest risk relative to a single day of extreme temperature. So these heat waves is the focus that we should be having, but there's still quite a bit of harm with single hot days, as we found. Heat waves characterized using this combination approach, so when it's hot and it's humid, were found to have greatest effects on death, and those lasting longer periods. So those 3 or more days were associated with slightly higher risks of death and emergency department visits, but not hospitalizations. And this is interesting to understand what's happening, of course. All right, so we'll just stop here again just to see if anyone has any immediate questions on part 2. And and if not, we'll just continue on. So part 3 was really looking at exploring the mitigating effects by both green, so vegetation, and blue, water spaces, residential proximity to these spaces. So we found negative effects in the whole population. So now we are saying, okay, let's break up this population to see how does it differ in terms of those squiggly lines when you look at people who live in areas that have more green or closer to water versus further away or less green. So these are the results that we'll show. We used Canoe data, as I mentioned previously, to define both green and blue space. Canoe provides many different measures of green space. The normalized difference vegetation index is the most commonly used index in green space research. So that's what we chose. But and there's many of these NDVIs to choose from. What we did was choose the growing season mean value for this analysis, but there's sort of like the annual value, which would then, average across winter and summer, which we're not interested in because we were focusing specifically on summer months. And we divided these groups, or we decided to divide these groups, and we did do it actually, but according to the median of the NDVI value for the whole New Brunswick population. And so those who were having higher or NDVIs that were higher than the median were classified as the higher greenness group, and those below the provincial median were classified as lower greenness levels. But we have to acknowledge that the range of NDVI in New Brunswick is very narrow, and we found that a lot of people were at that median. So being able to distinguish between people who are below, lower, and higher was a little bit limited based on the distribution of the data that we had. So this would also warrant further examination, I think, and exploration. We did, and I didn't mention it here, but we also looked at a different green space value through discussions with Julie and talking about the limitations of this, because this is just capturing any green. So like a field is the same as a tree, which we know that trees have shading capabilities and maybe grass doesn't have that same impact, whereas this wouldn't necessarily capture those differences. And so what we also did was conduct a sensitivity analysis looking at a variable that captures the density of tree canopy represented by certain characteristics of the trees or bushery. So blue spaces we assessed by quantifying 1 kilometer proximity to various water bodies. And again, all our proximity analyses are based on someone's residence. So where they live for most of the year, not necessarily maybe their cottages or summer homes. So this is a potential limitation here. And so Canoe provides blue space data, so proximity to oceans, to lakes, to tidal rivers, canals, and other water sources. We were really excited to get these data, but once we got them and started to explore them, we noticed that there was a lot of limitations in this, especially with these tidal rivers. So most of that data was missing, which, as we know, New Brunswick has an important river that runs right through it, which we couldn't capture in this analysis. So we would need to identify more complete data to be able to do this. We stratified the analysis using the same modeling framework that we talked about previously. And the modeling framework also has an additional limitation that, because it's so complex, that there's no way to statistically compare two groups. So we had to do that qualitatively. So this is the main result for the green space analysis. We really found only effects for death. The other outcomes, we didn't really find anything interesting. What we did find was at a humidex of 36, those people living in the low greenness group had an 8% increase, an 8% increase of death, whereas those in the high greenness had a 2% increase of death. And that wasn't a significant increase if you're looking at the confidence intervals, but they're all very close. The temperature, I had a temperature of 30 degrees Celsius. Those in the low greenness area were a 7% increase, and the high greenness area had null sort of increase, no difference with respect to heat. And so When we looked at results using the tree canopy variable that I mentioned, they were very similar, like the estimates were very similar, but the lines seemed to distinguish better. So this was what our hypothesis was, that using a more specific green variable that we may be able to get more defined results, and which is what we found. But they were very similar. Yeah. All right. So I mentioned blue space, and we were quite excited to do that, but we had a lot of limitations and we couldn't really undertake this analysis for methodological reasons. I mean, we did undertake it, but through that work, we weren't confident in what the results were giving us. So we decided not to show them. And we will, aim to potentially explore this as future work, because I know this is, a potential informative policy piece. So New Brunswick has a large tidal river system, and blue space data was just not available for that. There was some, but it was very limited. Only residential proximity to lakes was possible to examine. So people near lakes and oceans, or so people who have cottages or summer homes wouldn't be considered in this analysis as though they're living close to, because we're based on residents. We did find that people who live near lakes and oceans have different characteristics than people who live further away, as we also expected. So we thought that that might be driving some of the strange results that we were seeing. Sorry. The modeling approach that we use, this DLNM, doesn't allow for control of individual level factors, which is important for this analysis when we're stratifying. So that's an important limitation of when we break up groups. We're not able to validly compare those groups because they may have different characteristics. For the blue space, we did explore, and they certainly did. Individuals who spend time in summer residences living close to water bodies can't be captured in this data. All right, so takeaways, green space, New Brunswick has a high vegetation index with very little variability, and people on that cutoff of the median didn't really differ too much from each other, and a lot of people were there. The extremes weren't as dense. In terms of population, not trees. The risk of death on hotter days was lower in areas with more vegetation. So there's certainly something going on with green space, which aligns with what we found in some studies in the literature, but it's inconsistent with what we found, at least. For emergency department visits and hospitalizations, or for urban areas, we found similar trends. So we didn't necessarily see an impact, but as I mentioned, with the blue space analysis, we are unable to control for differences in those populations. And so for future work, this will be an important part of selecting a modeling approach that still allows us to do all this complicated stuff, but allows us to also adjust for these individual level variables. Blue space wasn't able to be done because of methodological reasons, which I explained to you already. All right, so just wrapping up. So some overall conclusions. So, extreme heat events, especially heat waves, lead to increases in negative health outcomes, with mortality showing largest effects. But as I mentioned early slides, we don't have many deaths daily. So, a 20% increase in death, you can decide what that means. We found that urban areas had more pronounced effects, which is what we were expecting based on previous literature, that urban areas have impacts of heat, urban heat islands, and other pieces that help contribute to increased feelings with respect to the same temperature, for example. Vulnerable populations appear to be impacted early. So on that first day of hot temperature, which leads to this temporary decline in risk in subsequent days, which we identified is referred to as a harvesting effect, with an emergence in several days after that single hot day. And so this was, as I mentioned, common that we found in the literature. But we didn't see any studies that did this in Canada, for example. Heat waves with both high temperature and high humidex showed the greatest impact, and greater vegetation was found to have some mitigating effects on reducing deaths on those hotter days. All right, so just to give you some sense of what the strengths and limitations were of our study, we used population-based sampling. We had a longitudinal study design in the sense that we used 15 summers, but also 5 months of each summer. So we were able to follow people over all those periods of time. Each individual served as their own control because we used cohorts that were residing in the province for that whole period. And I should mention also that we didn't, if people moved within the province throughout the summer, we just retained their first address. So if someone moved from Fredericton to Moncton, for example, in July, for that summer, they're defined as their original address. I forget what I said first. We linked environmental and administrative data from different sources, which is possible because of the NB-IRDT research data center environment. We used multiple heat metrics, so we looked at both temperature and humidex. We found some studies chose one or the other. So we looked at both, and we also looked at other metrics, but we identified that these were appropriate to use in our work. We evaluated different heat wave definitions based on established criteria, but also varying criteria from those established criteria to understand what different heat experiences may relate to different outcomes. Our analysis allowed us to both examine immediate effects on the day, but also in the days after that heat subsided. So these are called delayed health impacts. Of course, there's always limitations mentioned a lot throughout, so these aren't going to be a surprise to you. We had inability of weather data to reflect someone's individual exposure. So these are based on weather stations, and we know New Brunswick has, very interesting microclimates. For example, we used to drive to St. John to get air conditioning during the summer without the bugs. So it allowed us to, have that experience, so that exposure wasn't necessarily classified appropriately. So there's limitations there. The modeling framework we use is very, very complex. So that's a potential limitation, was being able to interpret the results and for people who are not necessarily familiar with this approach, but I hope that you understood what we were trying to emphasize. We tried to make it relatable. Smaller sample sizes and the inability to control for confounding in stratified analysis. So we're breaking up the groups, and so we're going to expect wider confidence intervals. We certainly had some data limitations, of course. We have amazing data, but there's always some things that we would want more of. So as I mentioned, ED data was only available for 5 years. I haven't mentioned this yet, actually. So we don't have good data or we don't feel confident enough in the data to be able to look at heat specific outcomes as a first step. So this work is based on all cause outcomes. And as part of future work, we really would like to explore heat specific data in these data sets to understand what that would look like and what impact that may have on the analysis. Blue space data was limited for rivers. We didn't adjust for pollution because we didn't have the data yet, but it is something that we found from the literature is always included, or not always, but typically included, but the influence of the pollution on the model estimates tends to be minimal, and New Brunswick pollution levels tend to be quite low. And we also don't have individual level socioeconomic data. It's strictly restricted to area level. So I mentioned area level socioeconomic characteristics. All right, so just like putting in the context of other research, so most Canadian studies have been conducted in Quebec, Ontario, and BC. So nothing that we identified, at least in New Brunswick. If you're aware, we'd love to hear about it. So different study designs and outcomes definitions really limit the direct comparisons that we use to other studies, but we found that generally our findings aligned with those of the previous Canadian studies. So we think that maybe this high risk of mortality in New Brunswick may be due to our older population and a higher prevalence of chronic diseases, especially comorbidities as well. Comorbidities that lead to heat vulnerability, for example, diabetes and respiratory conditions like COPD. Immediate hospitalization spikes suggest that care in hospitalization is sought promptly rather than delaying that healthcare access. And that delayed effects may be due to some illnesses taking longer to manifest or delays in seeking medical treatment or in limited healthcare capacity. So we think that perhaps some of that, those delayed effects are not observed for emergency department because of the need for an emergency department here and the limited capacity. We also found that increased out of from the literature, that increased out of hospital deaths during heat waves may reduce hospital admissions. We didn't sort of look at this in great depth, but would be worth to do as part of future research. What we did, and I should mention, I don't know if Terry's on the call, but in previous phase 1, we sort of considered day of admission as the day of outcome. But in phase 2, if someone was admitted to emergency room like today, and then they went up to the floor tomorrow, we counted today as their exposure period. So we were able to better assign that heat. So mitigating effects have been explored in a few Canadian studies, both green and blue space. Findings on protection from green space are inconsistent across studies, but we found that there were limitations in the way people use this NDVI value. For example, I think it's a Quebec study, and Farnaz can correct me, but the Quebec study assigned one NDVI value for like a health region equivalent in New Brunswick. So that's a large area and a variable potential NDVI value. So some of the research on this inconsistent may be related to methodological reasons. And NDVI does measure all vegetation. So in an area, if more trees, it's not necessarily the same as an area that has no trees and only fields. And what we found was that the tree canopy variable for green space may provide a better measure. Most research on blue space has been conducted outside of Canada, but the studies that have been conducted in Canada don't connect the heat piece necessarily with the blue space. So this is certainly an area for more research. The lack of mitigation by blue space is likely due to data limitations and confounding factors, and future research should really aim to use more complete data and choose analytical methods that allow us to dig into this more specifically and derive an unbiased estimate.